Hello and welcome everyone to GBMC's Greater Living. I am Mary Beth Marsden. How are you today? Great. Yeah! I love a crowd that answers back loudly. Thank you for that. We are talking this next hour about breasts. Breast cancer, you know, save the tatas. This is the month for that. But really, I think it almost goes beyond saving the breast. We're talking about saving lives, right? Because I mean, I think that's what we all care about in the end. So there's so many questions about breast cancer. Believe it or not, even with everything we know, I think women and some men are getting mixed messages about diagnoses, about when to get checked, screening, et cetera, and we're here to give you all the best answers that we can. And we're starting out of the gate this hour with Dr. Sara Fogarty, who's a surgeon and Associate Director of the Sandra and Malcolm Berman Breast Care Center at GBMC. I think some of you are familiar with that. And we're just going to be talking about breast cancer, your risk, and what can be done if you do receive a diagnosis. One of many, I guess, because it's not just one diagnosis. Every case is so different, which Dr. Fogarty or Sara, as you asked me to call you. And thanks for being with us.
Thank you.
You know, we were talking about breast cancer off camera and how it's, you know, yes, it's a science. There's medicine involved, of course, and research, but it is truly an art form. It's every person is so different, and how you respond to what they're dealing with is different. So we're going to get something kind of out of the way in the beginning, and it was a question that kept coming up, and I think as women get older and they hit that 40 mark, everybody still wants to know, because we've been getting mixed signals and different recommendations. When should we start screening? How should we be screening?
Sure. It's well, thank you. Thanks everybody for being here. It's a very complicated question because there are so many different recommendations. And this year at our national meeting of the American Society of Breast Surgeons, which is every breast surgeon in the country is really part of this group. And we have a national meeting once a year, which is founded by the American College of Surgeons, which is what all of us train as general surgeons, and then go into breast-specific surgery. And they really did a push about they are accepting life, and they want mammograms to start at 40. So they were going against the most recent recommendation from the United States Task Force, saying that mammograms should maybe start at 45. They maybe shouldn't be every year, maybe every other year. And this is a conversation you should be having with your doctor. The previous recommendations, I think in 2009, even said that we shouldn't start till 50. And that's what they do in Europe. So at 50, you start screening mammogram, and they're usually every other year until age 70, and then you stop. This country has always been different, and there's a lot of research and a lot of strong opinions on both sides of the screening recommendations. It's a very controversial topic.
Can I just, why is it so controversial? I mean, it's screening.
Yeah. So
what's
the risk, right? There's always, we always talk about risks and benefits with everything we do. And so the risk of mammograms is, what if you're doing a mammogram in a woman that doesn't need it and there's a spot that's found? And what is that spot? They're getting extra callback images. Every mammogram has a very, very tiny dose of radiation, but it's still radiation. And then maybe they get a biopsy that isn't needed, and so they're getting a procedure done to them that's unneeded because it was a false positive reading on mammogram, and then they get a needle biopsy, and that biopsy comes back negative. Do we believe that biopsy? Sometimes there's issues with the imaging. If it looks really suspicious, the biopsy's negative or benign, and then we say, well, is that really real? And it causes a lot of anxiety to women, and we're doing procedures that maybe they didn't need. So there's a lot of back and forth about the benefits and the risks of doing mammograms early. The ASBS, which is the society that I belong to, now recommends 40 every year. And there's, of course, the newer methods of 3D mammography, which really does help and is a significant improvement in the previous 2D mammography, where we really can see through denser breast tissue much easier. And so that's something that for all 40-year-olds, really you should be having a 3D
So really
mammogram. Everyone
should be getting 3D mammography. It used to be, I remember, it wasn't always the case.
And it's not a blanket statement.
But should you at least ask for it?
Well, women that are young, that are going to have denser tissue, the younger you are, when you're still in childbearing years, your tissue is going to be denser and it's going to be harder to see things. So I don't have a picture to show you, but a mammogram, the tissue looks white when it's very dense. And tumors, either benign or malignant, or cysts that are benign, show up as white. So it can be hard to see through the tissue to actually pick out if there's an abnormality or not. So 3D really does help us with that. So 40-year-olds, what I'm telling everybody is that if you have no elevated risk, and we'll get into that, that you should be starting screening at 40, and it should be once a year. 3D is likely the recommended study. If you're 70, that might not be what you need. A 2D may be absolutely appropriate, and you don't need more. So it really depends, and it's.
Are we talking about every year for the rest of your life?
So the next question is, when do you stop?
Right.
And that's also complicated. There's no real good data showing when you stop. Basically, the recommendations the ASBS put out was if you have at least 10 more years to live, you should be getting a screening mammogram every year. So based on your other medical problems, if you're 85 and you are playing tennis every day and take no medications, then you should still be getting a screening mammogram. At our center, we tend to say when you're 80, we should stop. There's a lot of controversy about that. I have 90-year-olds coming in with an abnormal screening mammogram. It's like, wow, I can't believe you're still getting screening mammograms.
And that's an age where not everyone's really created equal.
Absolutely not.
It can look very different. 80 can look very different from one person to the next.
I have 50-year-olds that shouldn't be getting screening mammograms because they have so many other medical problems. Bad lungs, bad heart. Is it really important to be screening them? So it's a conversation that needs to happen with every woman with their primary care doctor or their gynecologist, whoever's ordering these studies for them, when to stop. But the recommendation now is that if you have at least 10 years left in your life expectancy, you should continue screening.
And then I think when we've had conversations about breast cancer, and I think by the time you're 30, I feel like, you know someone who's been touched by breast cancer. I feel like everybody knows someone.
Yeah.
And the older you get, the more people you know. Mm-hmm. And the question I always hear, at least my contemporaries ask, how did they find it?
Sure.
Was it a mammogram? Was it, we just want to make that designation for some reason because it reinforces what we're doing or not doing to get us to do it. Mm-hmm. So let's talk about self-examination as well.
Sure.
I mean, it's still important, but...
Yeah, so, remember in 7th grade when they gave those cards out where you're supposed to do those little circular pattern in the shower. That provokes a lot of anxiety in women too. I'm not doing this right. What am I feeling? I tell women that are younger, that have family history of breast cancer or that know someone that had breast cancer that of course are coming to see me because they're worried about something. Is this a lump? Is this real? Too young to start screening imaging. So the 25 to 35-year-old group where they don't know what they're feeling. Really, it's more about self-awareness and understanding what's normal for you and if something's changed. How they do that, I don't really care. I don't care about that whole, circular pattern. Get to know
your body.
Exactly. And so it should be the week after your period ends that you examine yourself because before and during your period, your breast tissue can feel a lot denser, lumpier, more painful, and it can be very, anxiety-provoking. So really just self-awareness and knowing if something is new or different for you and then alerting your physician, I think I feel something that is not normal for me, to come in, and then you should get appropriate imaging.
And is that the only symptom, the lump or the feeling of something hard?
No, there's a lot of things. So I always tell women to look for lumps, of course. Nipple discharge, especially bloody discharge, that definitely does not mean they have cancer, but bloody discharge should be worked up. Nipple discharge is very common in premenopausal women, and I see it a lot, and it's usually physiologic, meaning it's normal. But if it's something new, you should get it checked out. Some women complain of thickening of the skin, and that is a symptom that could potentially be a cancer. Certain types of breast cancer grow more as sheets and not as balls, so you don't feel a lump, you can feel just a thickening in the area. Rashes or redness on the skin, lumps under your arms, lumps above your collarbones, nipple changes where the nipple is changing direction or pulling in or retracting. Those are all things to look for.
And these, by the way, are questions that came in via Facebook or other social media. So these are women who really want to know about this and maybe somewhere along the line have not been told.
Yep.
Another question is from a woman, and this, I think women know that their breasts go through changes throughout the month, and sometimes they're more painful. And she's concerned about the pain that she may feel.
So the standard teaching is that pain is not a symptom of breast cancer. So breast cancer is usually a painless thing, a painless lump, a painless abnormality on a mammogram. I have a lot of women that come in with breast pain, and there's a lot of reasons for that. Women with really dense cystic breasts can have breast pain that's especially worse before their period and during their period, and then usually resolves. It's called cyclic breast pain. So with their menstrual cycle every month, they get pain that's worsening, then it gets better after their period's over, and it happens again the next month. That's very common and very benign. I have women that, I do have women anecdotally that say to me, I've had this tingling or weird feeling in my breast, and then they do get diagnosed with breast cancer. Is that related? I don't know. The classic teaching is that no, it's not.
But they sensed something, so who are you to say?
I see a lot of women with breast pain that come in, and that's absolutely reasonable to do that. Caffeine can affect pain. Certain medications can. Sometimes it's a musculoskeletal problem. Sometimes physical therapy is needed. I see a lot of women with lots of different reasons that they might have pain. Sometimes breast size can do it, and they're not wearing the right support.
I was just going to ask you, okay, I just thought this was the dumbest question ever, right? Yeah. So it would stand to reason if you have large breasts, there's more opportunity for something to be in there than a smaller breast. Do you know what I'm saying? So if you have more breast tissue, bigger breasts, is there a greater chance of developing
breast
something?
Cancer?
Yeah.
So I'm not sure about the size.
No one's ever kind of...
The density. So if you have very dense tissue, that does increase your risk. And so our risk models that we use, which are computer models that I use to help assess a woman's risk of getting a future breast cancer, which aren't perfect, but that's what we have to use. The newer model takes into account breast density, and that does increase the risk. The models we use probably overestimate that risk from the density, but it is something that we do consider.
So you walk a line, right? You don't want to freak women out, and at the same time you want to give women knowledge, but
Most women are very anxious about all of this stuff in the first place because they saw somebody with breast cancer or know what could happen. And so, a lot of what we do at our center is trying to make people reassure them, alleviate their fears. I do a lot of reviews of imaging that is questionably abnormal, lots of pathology reviews, going over these things, lots of short-term follow-ups to make sure we're not missing something. And this is what all breast doctors do. Because there's so much out on the internet. There's so much that you hear about that's probably not true, but it's a lot of anxiety. All cancer invokes a lot of anxiety.
And yet at the same time, it would be a shame if people didn't have knowledge.
Of course.
So, you kind of try and figure that out.
So in regards to symptoms, anyone that has anything new, it's absolutely appropriate to talk to your gynecologist or your primary care doctor. And if they feel that they need to be seen by a breast specialist, that's absolutely appropriate.
Yeah.
And we see a lot of those, patients that are have no cancer, that have benign issues, but that we see to reassure and make sure we're working them up properly to rule that out.
Yeah, and if you keep Googling it, you're just going to spiral.
Yes.
You need to really speak with an expert. Someone wrote in and asked about a family member who has breast cancer, and should the mammograms start at a younger age? Does it depend on the family member and when they got it, or
so recommendations from the NCCN guidelines. These are the National Comprehensive Cancer Network guidelines that all of us used. How we treat patients with breast cancer. They say that women who are have a family member diagnosed with cancer, mammogram screening should start 10 years before that age of diagnosis. But if your mother was diagnosed at 30, I'm not starting mammograms at 20. That's too young. Mammograms aren't going to be helpful. We usually don't want to do mammograms before the age of 30 because the breast tissue is usually so dense, it's not going to be a good study. It's not going to be helpful. So the question comes in, do we do MRI? Do we do anything? Do we just do a clinical exam and watch them a little closer? And those are things that we have conversations with also, about with patients all the time.
And now with genetic testing, of course, there's always questions about if you do have a family member, do I have the gene?
Sure. That's a huge thing. And we actually just had a big symposium on this last week with one of our genetic counselors who presented, and our geneticists and one of the gynecology oncologists, where we were addressing these issues about genetic testing and high-risk evaluation to our primary care and gynecology physicians, because they're the ones that these women are seeing first, usually 25 and to 30-year-old, that age group. They may not be seeing a doctor at all, or if they are, they're seeing one of those doctors maybe once a year, maybe. And so the question is, these new recommendations about should all women in that age group be getting a high-risk assessment? And that's what the ASBS has put out as well, that all of these women should be getting a risk assessment done, a formal risk assessment.
If it's in their family?
No.
All women?
All women. So this is a huge...
I don't think that message is getting out yet.
No, well, it's brand new.
Okay.
So it's it's going to be a huge change in what the primary care doctors are doing. You know, a lot of women would say, well, my mom and aunt had breast cancer, and they say, oh, well, then that means maybe you should see the genetic counselor or you should talk to a breast specialist. But if they don't have that family history, they're not assessing them for risk. The idea is that we're missing women that may potentially have a genetic mutation or maybe at higher risk, and maybe they should be getting screening earlier than the age of 40. So this is a big push that our center is streamlining a high-risk clinic where we have a website where patients can actually fill out this information themselves.
So these younger women can come right to you and not necessarily go to a gynecologist.
Well, they fill out this form and we do a risk assessment on them to see if they actually are high risk and need to come to us or not. So.
And at this stage in the game, how many genetic mutations can we actually test for?
Lots. So
really?
Much
but
different than
BRCA gets all the press.
Right, so BRCA gets all the press. So initially it was just BRCA 1 and 2, and now we have panel testing. So this is one of the reasons that having a genetics program and a genetic counselor is so important. I do not ever send genetic testing. I don't think anyone that's not a geneticist should really send genetic testing because it's so complicated now. There are so many genes that we know about that are involved in breast cancer syndromes and other cancer syndromes. So whenever I have a woman that comes in that's being evaluated for high risk, once I do their model to see if they actually are, or if they've already come in saying, I had this model done and I know I'm high risk, should they be seen by a genetic counselor? Depending on their family history, and if any of their family members who had cancer have not been tested, their family member should be tested first. The woman that was affected with the disease. Only then would the woman that's higher risk, if it was the daughter, if their mother had breast cancer, had a mutation, then the daughter would test. Does that make sense? So
it does, and my mother had breast cancer, and I never was tested.
No, well, she should have. If your mother
and she never was.
Was she young when she was diagnosed?
She was 45.
Yeah.
So she's a 35-year survivor.
That's great.
And at the time, they told her it was garden variety breast cancer.
Right. And at 45, so 35 years ago, we didn't have any of this.
Right.
So BRCA genes get all the press. They are the most common of the genes that we know about, but the risk of that in the population is like 5 to 7%. So it's very uncommon.
Except that if breast cancer is diagnosed, that would affect how you would determine a course of action, right? If
the gene, not always.
Okay.
No.
Okay.
So it depends. There's a lot of...
And before you go on, I just want to make sure, there is all this genetic information at the Breast Cancer Center, right?
Yes.
You have all of that.
We have an entire genetics department.
Okay.
And we have a wonderful genetic counselor who sees all of our patients for us. And the geneticists, we have physician geneticists who also review everything, and they decide so there's different panels to test. We can just test one gene, we can test 9, we can test 23, we can test 46. I don't even remember. There's so many different panels.
Do you find that every time like a star like Angelina Jolie comes to mind?
Yeah, well, that's...
But I mean, I would imagine your phones light up when the news comes out that they're taking...
Sure, and so everyone thinks they have a BRCA mutation, when in reality, not many people have that mutation.
Okay.
It is the most common of all the breast cancer mutations, but it's not that frequent. So, of course, when she came out saying she was a BRCA mutation carrier, her mother had ovarian cancer at a very young age, and she took steps to help reduce her risk of getting these cancers. In a woman that has a mutation, like a BRCA mutation, there's things that I would definitely be recommending to them about more aggressive screening imaging, potentially surgery. These are all things that we talk about to help reduce the risk of getting a breast cancer or any of the other cancers associated with that gene. There's lots of different genes we know about now, and each one has different recommendations about screening.
Again, everyone's an individual.
Right.
So I want to kind of move the conversation more forward,
Sure.
And this is once a diagnosis happens.
Sure.
So you find a thickening or a lump or whatever it is, and you biopsy it first. Is that?
Yes.
Okay.
So we get imaging done. So
Okay.
if they come in with a symptom, then we want to make sure we do a mammogram and usually an ultrasound. That's the way we start and see what that shows. And if there is a clear abnormality, then we do biopsy it by image guidance. So my radiologist will do that for us. And then once we get the pathology back and know that it's a breast cancer.
Which takes a couple of days?
Couple days, yeah.
It can be a long couple of days.
Yes, it's terrible.
Yeah.
It's usually 3 to 4 business days, I would say. Sometimes it's faster, it just depends. And so as soon as we get those results back, then we have a long conversation about what type of breast cancer it is and what we need to do to treat it.
Okay, and broadly speaking, how many different types of breast cancer are there? Sure. And do you break them down in sort of into subsets?
Yeah, so there's a lot of women don't realize this. There's the hormone receptor positive cancers, the cancers that are estrogen sensitive. And then there are the cancers that are estrogen negative. And then there's also something called a HER2 receptor. So these are different biomarkers we always test on every new cancer diagnosis.
And some are easier to treat than others, correct? If you're hormone receptive, that is easier to treat?
Easy, I don't know if I'd use the word easier.
Okay.
It's different. It's different. So the question becomes, when we talk about breast cancer treatment, there's lots of options, which is good. There's a lot of different cancers where there aren't a lot of options. And in breast, we have so much information and so much research that we've done for so long. We have a lot of options for treatment. Surgery is always part of that treatment. What type of surgery? It completely depends. We always strive for breast.
Okay, sorry, I'm taking you down a road. So we've talked about the different kinds of diagnoses, right? I don't want to get too far without veering off.
Sure.
So you get these diagnoses. You talk to your patient about how big it is or how far along it is.
So there's staging.
Staging,
right?
Okay, and then the options.
Sure.
And the options can oftentimes, if not most of the time, be surgery.
Yes.
Some type of surgery.
Some type of surgery. There's radiation. There may be chemotherapy.
And we are going to be talking about radiation quite a bit.
Yeah. There may be chemotherapy, not always. And there's hormone therapy too. So there's lots of different parts to the treatment plan that can be very different from one patient to the next.
Okay, here's a question I have, and maybe others do too. When you're faced with the surgery option, you have a diagnosis of some form of breast cancer, and I know that the surgery depends on the type of breast cancer and where you think it might be, right? There are some breast cancers that are slower growing and some that are more aggressive. Is that fair to say? And triple negative would be, for an example, of an aggressive. And so you, as a surgeon, give recommendations based on past outcomes as to what?
Based on data and all these clinical trials that we've done on patients with the same type of cancer.
And do you tend to stay more conservative as far as invasiveness of the surgery goes, or does that depend on the patient? And I'm asking this because, honest to God, my friends would tell you right now that if they had a tiniest little lump, they would want it all taken off.
Yeah, okay. So now I get where you're going.
Do you see where I'm going?
Yes, I didn't know where you're going. There's a lot of data to show that having a mastectomy has no survival outcome, improved survival outcome compared to a lumpectomy followed by radiation. So I have that conversation with everybody to explain why medically it's okay to do a lumpectomy and remove that tumor and to leave the rest of the breast behind.
I don't get it.
Okay, so.
Like you would have a hard time convincing me.
Okay, so and
I'm sure there are other women, right?
Yeah, I do. Sometimes I do, not usually, but sometimes I do, because we have a long conversation about this.
Right.
So a long time,
Does anyone else see that?
So in the 1970s, they started doing a lot of clinical trials looking at women that came in with a lump. So this was before mammogram screening was like the mainstay. No one was getting mammograms yearly. Women would come in with a lump and they said, well, do we really have to remove the entire breast? What would happen if we just removed that lump? And so they split the women into these trials. Half of them got mastectomies and half of them got a lumpectomy. And of the group that got lumpectomies, half of those got radiation afterwards to the entire breast that was left, and the other half didn't. So there was a mastectomy group, a lumpectomy alone group, and a lumpectomy with radiation group. Does that make sense?
Yes.
And what they found in following the recurrence rates and the survival rates of the women getting a mastectomy and the women getting a lumpectomy followed by radiation is that they're basically the exact same over 50 years now.
So the key is the radiation if you have the lumpectomy.
Yes. So the standard.
What about the women who?
So the standard for breast conserving surgery, when I say breast conserving surgery, that means lumpectomy followed by radiation, and that is the standard of care.
Okay.
So the women that had no radiation, they found that they recurred much more often, but not even more than half of them recurred. So more than 50% of them didn't recur. Why not? Those were usually older women. So women over 70. And my partner at the hospital actually did a big study on this about 20 years ago that proved that women over 70 don't need to be radiated if they have a good type of tumor with very good characteristics, meaning the small estrogen positive type without obviously gross nodal involvement.
How often does just a story that goes the other way or flies in the face of that research, how often does that cause you to really try and reassure that this research is solid and proven? Because you're always hearing the story about the woman who chose or was recommended to have the lumpectomy and the radiation, and something came back.
I don't know if I'm always hearing that story.
Okay, I am.
You are.
But I'm
not
just
always
hearing
that
stories.
story.
I'm speaking as the layperson woman who's talking to other women.
Doing a mastectomy, that still could have happened. Just because you have a mastectomy, it doesn't mean it can never come back. And so doing that bigger surgery off the get-go doesn't necessarily mean that wouldn't have happened this time around anyway.
Okay.
Does that make sense?
Yeah.